Okay, so our presentation is on methanol poisoning. Okay, so for this case study, a 6-year-old girl was admitted to the emergency room after reporting nausea, vomiting of food content, abdominal pain, difficulty breathing, salivation, headache, blurred vision, and psychomotor agitation 4 hours after eating. Additionally, the patient's skin was pale and her eyes were sunken, underreactive, clouded, and were irritable to stimulus. Upon initial investigation, we treated the patient for severe dehydration from food poisoning. However, when she went into respiratory stress, began wheezing, and became unresponsive to stimuli, she was admitted to the shock trauma unit to receive ventilator support. Okay, so upon laboratory examination, the patient had yellow urine, she had a blood pH of 7, and a hemoglobin count of 12 grams per deciliter. Furthermore, she had a sodium concentration of 133 MEQs per liter, a potassium concentration of 6 MEQs per liter, a chloride concentration of 107 MEQs per liter, an aspartate aminotransferase concentration of 4,490 IUs per liter, an alanine aminotransferase of 8,030 IUs per liter, and a lactate dehydrogenase concentration of 2,609 IUs per liter. Furthermore, her arterial blood gases demonstrated that she had severe metabolic and respiratory acidosis with a high anion gap. So, based on prior knowledge from class, how do you think metabolic acidosis would affect the pH of the blood? Okay, so hopefully you said that metabolic acidosis often lowers blood pH, making it more acidic. In addition to acidosis, the patient also presented with an oxygen partial pressure of 108 millimeters mercury, a CO2 partial pressure of 26 millimeters mercury, and a bicarbonate concentration of 3 MEQs per liter. So this slide compares the patient's laboratory results with normal laboratory results. So after looking at this table for a little bit, what results do you see that are abnormal? Okay, so from these results, we could conclude that she does have an elevated heart rate of 148 beats per minute, a slightly elevated respiration rate of 32 breaths per minute. Additionally, she had elevated concentrations of aspartate aminotransferase, alanine aminotransferase, and lactate dehydrogenase. Additionally, her CO2 partial pressure and her bicarbonate concentrations were lower than normal. So this led us to assume that the patient either had diabetic ketoacidosis, salicylate poisoning, or methanol poisoning. So upon evaluation, glucose and creatine concentrations were normal, but urea had a slightly elevated concentration of 33 milligrams per deciliter. Furthermore, toxicology indicated a serum methanol concentration of 1.47 milligrams per deciliter. So how would you expect the patient's low bicarbonate concentrations to affect the pH of the blood, which is slightly lower than it should be? So you should have said that as we've learned, the partial pressure of CO2 does decrease, or as it decreases, the bicarbonate system will normally shift the reaction to the left, producing more CO2 and less hydrogen ions. This ultimately makes the blood more basic. However, the patient has lower bicarbonate concentrations than normal, likely making this buffering system less efficient, accounting for why the patient's blood pH is a little bit more acidic than it would be if she had the proper bicarbonate concentrations.
All right, so now we're going to talk a little bit about what methanol is. So methanol is a clear, colorless, flammable liquid, and its chemical formula is CH3OH, and it's also known as methyl alcohol, wood alcohol, burning alcohol, or carbonyl. It is highly toxic, and it's used in paints, varnishes, solvents, perfumes, plastic manufacture, photographic materials, antifreeze, and household cleaning products. Serious methanol toxicity has been most associated with ingestion, but exposure can also occur by inhalation or skin absorption. People at risk of methanol poisoning include bookbinders, bronzers, dyers, ink makers, painters, and chemical manufacturers. So, how do you think a child could accidentally consume methanol? Well, in our specific case, we know that a child frequently drank a certain soda and then accidentally drank a bottle of perfume thinking it was that soda. So it's likely that she got methanol poisoning by drinking the bottle of perfume because perfumes contain methanol. So what are some symptoms of methanol poisoning? These symptoms include central nervous system depression, headaches, dizziness, nausea, lack of coordination, confusion, blurry vision or blindness, acidosis, and tachypnea. We're going to talk a little bit about how methanol poisoning causes these symptoms. So, methanol itself is not toxic, but it is the degradation of methanol by alcohol dehydrogenase that releases toxic metabolites, formic acid, and formaldehyde. When ingested, methanol is absorbed via the gastrointestinal tract and follows a zero-order elimination rate. So you can pause the video here and think about what a zero-order elimination rate is. Well, this means that a constant amount of the substance is eliminated per unit time, but the rate is independent of the concentration of the substance. Metabolism of methanol mainly occurs in the liver. First, alcohol dehydrogenase oxidizes methanol to formaldehyde. Secondly, aldehyde dehydrogenase oxidizes formaldehyde to formic acid. Both of these steps involve reduction of NAD to NADH. Why do you think the reduction of NAD in these reactions is a concern? You might want to think back to cellular biology when considering this question. It's a concern because NAD is an important coenzyme for glycolysis, and if it is depleted, then cellular respiration and ATP production are affected. Due to the zero-order elimination rate, at high methanol concentrations, formic acid is not easily eliminated and it accumulates. So, methanol poisoning can cause CNS depression, as we said, and it's generally caused by the consumption of depressant drugs such as ethanol, and methanol can be toxic due to its CNS depressant properties in the same manner as ethanol poisoning. Depressants increase the activity of gamma-aminobutyric acid, which inhibits brain activity. For nausea, headache, and difficulty breathing, when high methanols of concentration are consumed, there is an accumulation of formic acid, which is toxic because it inhibits mitochondrial cytochrome C oxidase, causing hypoxia and metabolic acidosis. It inhibits the respiration chain in the mitochondria. And then lastly, for blindness, formic acid can cause blindness by the destruction of the optic nerve.
So, how was our patient diagnosed? Well, first we need to look at how methanol poisoning is diagnosed in general. So, methanol poisoning is diagnosed through physical examination paired with several different lab tests. Physical effects of methanol poisoning include visual disturbances, confusion, lack of coordination, GI symptoms, and severe neurological symptoms in extreme cases. The chemical effects of methanol poisoning can include an increased anion and osmolar gap, increased levels of certain liver enzymes, imbalances of arterial blood gases, and oftentimes metabolic acidosis. The most important lab in diagnosing methanol poisoning is obviously the serum methanol test. So in our patient, they came in and presented with vomiting, nausea, salivation, and abdominal pain, which are very common GI issues associated with methanol poisoning. They had blurred vision, which is a common visual disturbance related to toxicity to the optic nerve. Neurological issues, our patient presents with psychomotor agitation, and our patient's labs also show a reduced blood pH, leaning towards metabolic acidosis. As for liver enzymes, our patient's labs show greatly increased levels of AST, SGPT, and LDH. Our patient's methanol blood test also showed higher methanol levels in the blood, as we'd expect to see zero methanol in the blood. So, how can we treat our patient? For cases caught prior to the onset of symptoms, we can induce emesis or use a gastric lavage. This is basically just inducing vomiting or pumping their stomach in order to remove the methanol that they've consumed. If the patient is showing signs of metabolic acidosis, intravenous sodium bicarbonate therapy can be used to bring the pH back up. Hemodialysis may also be used to filter methanol from the blood. In the case of our patient, ethanol infusion will be used, as it acts as a competitive inhibitor. Alcohol dehydrogenase has a higher affinity for ethanol, meaning it will choose to bind to it rather than methanol. Ethanol, unlike methanol, has safer, less toxic metabolites. Hemodialysis may also be used to directly filter methanol from the blood.
Okay, so why would you use ethanol treatment in this case? So ethanol is actually a competitive inhibitor to alcohol dehydrogenase. So where do competitive inhibitors bind? So what you should have said is that competitive inhibitors bind at the active site. So this prevents your methanol from binding to this active site. And so how would this affect your Vmax? And how would this affect your Km? So alcohol dehydrogenase has a higher affinity for ethanol than it does methanol. So when ethanol is present, it's going to be binding to the active site of alcohol dehydrogenase much more than methanol will be binding, reducing the effects of methanol. And by reducing the effects of methanol, this is going to prevent alcohol dehydrogenase from binding to methanol and producing toxic metabolites, formic acid, and formaldehyde, which can lead to toxicity. So ultimately, ethanol is going it's not going to change Vmax, but it will actually increase the Km, meaning that the alcohol dehydrogenase will have a lower affinity for methanol than it does for ethanol.